members. This is a picture of the wonderful team. You will see 5 of those 6 faces today. The other one's on the phone. Colin Gallons, who's at the far left, or far right of mine anyways, your far left. Myself, Cecile Hunt, Tanis Thompson, Pat Stewart, and Cheryl Elliott. Our mistake proofing project looked at, as we mentioned, medication management in the ORs and use for anesthesia. Our region's had a couple of critical incidents, near misses associated with this, and that's what prompted it to be part of this. One of the things that we were looking at is the lack of consistency in labeling of drawn medications. Everybody used a different system or no system. One of the things that can result in is something like this, patient safety alert. So our team is really focused on what can we do to help the anesthetists avoid making mistakes, having the wrong medication in their hand. And our target sheet, we're really focused on the defects, making sure our goal is to have 0. Our initial observations, we had almost 7% of the time they have the wrong medication in their hand. Didn't necessarily mean it got to the patient, but they had to pick it up and then put it back down and get a different one. And we also want to do this without increasing the amount of time it takes for them to draw the medications and label it.
So here's our anesthesia value stream map. The value stream map focused on the patient's medications being drawn and administered. Depending on the length and the time and the type of surgery, the medication administration may occur multiple times or infrequently during a surgery. We found there were a number of opportunities, including a review of the setup of the anesthetic cart, where the drugs and supplies are located, also to standardize the process for labeling the drawn medications, and to standardize the preparation of the rescue drugs. When you look at the value stream map, in the middle you can see the part about the medications being administered, and that's where the arrow is in the middle. And so we looked at those focused process steps of drawing up the medications. And the cycle time for this process was 60 seconds. The value added time was 35 seconds, or 58.3%. And the non-value added time was 25 seconds, or 41.7%. We considered non-value added time, the 25 seconds, as the labeling process was ineffective and puts the patients at risk of harm. This is a time observation form, and pre-Kaizen, and the process of drawing up the meds took 1 minute. This is a process map for anesthetic medication administration. And what this shows is that each anesthetist had their own system of preparing, labeling, and administering medications. Some use different colors of tape to label with or without writing, and others draw up the medication and immediately give it to the patient with or without labels. And some just use different sizes of syringes to indicate the type of medication. So there is no standardized process for labeling medications. This lack of a standardized labeling system is unsafe and it risks harm to the patient by administering the wrong type of medication. These are some pre-Kaizen pictures, and what you're looking at now is the top of the anesthetic cart. On the left-hand side, you can see some syringes with blue tape. Some have handwriting on the labels, and some don't. The color of tape indicates the type of medication. And this next picture just shows you a close-up of those medications. So this is a picture of a variety of syringes without labels. On the right-hand side, you can see that one does have a red label. That label is from the medication vial. And here are some other syringes of a variety of sizes without any labels on, and the size of the syringe indicates the type of medication. Here's a picture of the top of the anesthetic cart, and you can see there are a number of kidney basins. And in the kidney basins, there are a variety of syringes. Some colored tape, some with writing and some without writing. This is the anesthetic cart medication drawer, and as you can see, the compartments for the drugs are all labeled. There is, however, some inconsistency with labeling using the generic name versus the trade name. This is some PQA data. What it shows is that on average, patients in our region, 437 patients in our region, receive surgery on a monthly basis. And this is our pre-Kaizen defect data. And what our defect was the anesthetist selecting the wrong medication or wrong syringe. And that doesn't mean that the patient actually got the medication. The anesthetist just selected the wrong one. And our pre-Kaizen defect rate was 6.7%.
Colin, you're up.
So as part of our project, we met with the anesthetists and we asked them to provide us with a recipe card for us based on the following. The type of anesthetic, be it general, local, conscious sedation, or spinal. We also asked them to provide the medications they used, the dosaging and concentration, and the types of syringes that they would use. We got this information to kind of get a sense of what we would be able to do either with labeling or pre-manufactured syringes. Next, we asked pharmacy to provide us with a list of a stability chart so that we could look at safety issues and potential mistake proofing plans. Yep. So we contacted our printing department and we had some quick labels made up for us to use. And then we put them in a container, and that really was just put out for a trial. And then we actually were able to order some pre-printed labeling. And then from there, we actually, what the anesthetist chose was the pre-printed labeling. So another idea that we tried is the shadow board, and this was the alternative to the kidney basins everywhere, and what we did is we divided the shadow board into different types of drugs. At this time, the shadow board is being used, but it is being met with very mixed reviews, so that is something that we are going to continue to look at. The last thing that we did is we looked at developing standard work, and we developed standard work for the anesthetists so that they would all follow the same procedure while giving the medications. And lastly, we developed standard work for restocking of the anesthetist cart.
And I'm just now going to review the results achieved by our mistake proofing project. The labels for anesthetic medications were instituted. And as you can see, all of the labels are pre-printed. The physicians can document perhaps dosages that are specific and unique to the patient that they're caring for. And that these labels are all purchased from a standardized provincial contract. The labels will now be available in all of the 5 main operating theaters in the Victoria Hospital, as well as the obstetrical operating theater. And the standardized labels will be set up as in the upper right-hand corner of this picture on all of the anesthetic carts. Okay. This picture profiles that all medications drawn have a label, except for the propofol, which is distinctive and a unique drug in the operating room, and therefore it is only used in this environment, and the decision has been made that a label is not required. The anesthetic value stream map for the operating rooms is that, please note that this is the post-Kaizen value stream map, and that this project focused on a component of the value stream map, the selection, the draw, and the labeling of medications used throughout an operative procedure. And the lead time is 41 seconds. And we see that these 41 seconds are value added, that there is consistent use of labeling, and it's value added most of all because of the impact on patient safety. The non-value add in this process is 0 seconds because we are not using inconsistent labeling or no labeling at all. The time observation form, which is also post-Kaizen, our assessment showed that there was a reduction in the cycle for the medication selection, draw, and labeling, and that the value is added through consistent labeling, and it's focused on our patient safety. This is our process map that verifies our value-added component. On target sheet, the report and the results. You will note that we found 0 errors during our mistake proofing project once the consistent labeling was instituted, and that of course is the number of incidences where anesthetists selected the wrong medication. There was the creation of standard work, and our lead time resulted in a reduction of 19 seconds as compared to the previous pre-Kaizen of 60 seconds. Therefore, we had a reduction of 31.7% in this process.
As in any project, we had a few unfinished items by the time we got finished, so we have some things to leave to the capable hands of our sponsor, Dr. Asifa, and our process owner, Lesia. The first is we have still some training to do with our physicians. All of them have received training in the standard work around the drawing and labeling of drugs, of the anesthetic drugs. However, not everyone has been had their use of the standard work reviewed, and so you can see that some have still have to be reviewed. The next is we have some skills training to do with the nurses who stock the anesthetic cart. We actually use their work that they normally do to create the standard work, but now they all need to be, there might have been some variations, so now everyone has to know what the new standard work is and how they're following it. The other side with this is it's fantastic for new employees. They'll have something to use when training new employees. To our newspaper, we had some items come up that maybe during our project, although the project was, we were working on this for a few months, we had to really focus on a few things to keep going, but some really good ideas came up on how to improve patient safety while we were working. So we thought we'd put them on here and have some more work done on them. Something that comes to mind is the consistent process for preparing the medications used in the obstetrics OR. And so Lesia and Dr. Asifa are going to work to determine standard anesthetic meds, and perhaps they could have a package prepared and in the obstetrics. Also, there was concerns raised about the after-hours emergency surgeries and the medication preparation. And we were going to see if we could determine a standard package of medications and a process for storage and replenishment, so that those drugs also wouldn't expire just sitting in the fridge. There would be another process to use them up. And also, so the last thing we had on the newspaper is we do have to complete an audit process. And so I believe the plan is that we would have the audit process with a monthly review, and that would be a staff member, and Leslie would pick someone to do the audits this month, and they would go through the ORs and audit.
So the summary of our project, first thing we said is, really it's vital to have all of the clinicians committed to the project and understanding the goals. It would have been that we struggled getting everybody together when it came to these clinicians and getting them in a room to understand what was happening. Some of the other things was previous clinician provider experience and training can lead to different protocols. We've got people who've been trained and worked all over the world, and everybody does something different. Whether it's from their training institution or previous places they've worked, they've all developed things. And trying to get standards and understanding it's not necessarily that one is better than another, but everybody needs to do the same thing. We've learned a lot about how standard work will assist in consistent training for both new staff, physicians, as well as we have residents who are doing anesthesia. And when they come in and they're seeing training with 3 or 4 different people doing 3 or 4 different things, it's how do they learn? We also know that we need to do a better job of keeping the momentum going. It's really easy to lose track over a long period of time. You need to have a work plan early and stick to it. You got to work through the process steps, asking questions, testing solutions. And the one thing we really learned is when a mistake is made, we can really learn from it and look at what caused it and how we can make it safer for our patients. And our team has a whole lot of people we want to thank. First of all, Lesia and the staff in the OR for putting up with us coming in sometimes on very short notice or unannounced, asking for things and information. We really appreciate their help. Dr. Asifa, our sponsor, he helped out with getting the anesthetists together as much as possible and provided a lot of good feedback himself. I want to thank Lori and Monique and the pharmacy team for their help in helping us understand some of the meds and doing some research for us around that. Brad in the print shop, because he turned those labels around in a couple of days. And JBA and Virginia Mason, particularly in Seattle, we got a lot of really good tools and ideas on what we can do and ask questions and how we can push this project